Good afternoon. My name is Steph Kershaw, and I'm also joined by my colleague Tariq Hall, a Whaler One Man, and together we manage the Cracks in the Ice online toolkit, which is based at the Matilda Centre for Research in Mental Health and Substance Use, located at the University of Sydney. And it's our great pleasure to welcome you to today's Cracks in the Ice webinar. Before we begin our webinar, we'd just like to acknowledge the traditional owners of Australia and recognise their continuing connection to land, water and culture. I'm currently on the beautiful land of the Gadigal people and pay my respects to their elders past and present. And I'd like to further acknowledge the traditional owners of the country on which you are all on today and joining this webinar and pay my respects. I'd also just like to acknowledge that today is National Sorry Day. We acknowledge the strength and resilience of stolen generation survivors, their families and communities. And with National Reconciliation Week starting tomorrow, today is a moment to reflect honestly on the truths of our shared history in this country and the ongoing impacts of past government policies have had on Indigenous people. So today's presentation is one in a series of webinars if you haven't been along to part of our series before. So I'd encourage you to take a look at the Cracks in the Ice website and you will be able to stay up to date with any upcoming webinars as well as look at any previous ones that have taken place. Before we introduce today's speakers, I just want to let you know that as participants, you are in listen-only mode, and that means that we can't see or hear you, but you will notice that you've got a Q&A button on your dashboard, and this is where you can type in any questions that you have throughout the webinar and send them to us. We will also be having a dedicated question and answer section at the end of our webinar. So definitely send through any questions that you have. I'd also like to let you know that we will be recording today's session and making the recording available to you through the Cracks in the Ice website. So without further ado, I'd like to welcome today's speakers. So we have leading the presentation, Ms. Julie Matheson, who is a early career First Nations researcher at the University of Sydney. Sorry, is that correct, Julie? My notes just disappeared on me. She has experience working in neuroscience, mental health and addictions research, and she currently works as a researcher investigating topics related to addiction treatment and post-release support for First Nations people. And we also have Professor Michael Doyle, is a Bardi man from the Kimberley region of Western Australia. He's worked in Aboriginal health for over 20 years, commencing his career as an Aboriginal health worker at the Broome Regional Aboriginal Medical Service. And Michael moved into Aboriginal health research in 2008, and he is currently the First Nations Health Researcher Program, the lead of that at the Edith Collins Centre. He's a mixed methods researcher with a focus on AOD treatment for Aboriginal men involved in the criminal justice system. And Michael is also an active member of the Aboriginal community and has served on Aboriginal community control organisation boards, as well as being co-chair of the Aboriginal Health and Medical Research Council of New South Wales Health Research Ethics Committee. So thank you both so much for joining us today. It's our pleasure to have you, and I'll hand over to you to take it away with the presentation.
Sure. Thanks, Steph. I see you got the long version of the CV. That was a little embarrassing with the second paragraph. So thankfully, I'm not doing much talking. So saying speakers as in multiple is kind of to my benefit. Julie's going to be doing most of the presentation. But so look, thanks so much to the Matilda Centre and Steph and the team for inviting us along. I think you invited us last year and we weren't, or early this year, and we weren't able to do that one at that time. So today we're talking about the OLAM trial, or I should say Julie is talking about the OLAM trial, which is the Oral Lisdexamfetamine for treatment of acute methamphetamine withdrawal program. If we go to the next slide, perhaps, we want to also recognise the traditional owners of the lands upon which we meet. We pay our respects to elders and communities past, present and emerging of the lands that the University of Sydney campuses stand on, which for thousands of years they've shared and exchanged knowledges across innumerable generations for the benefit of all. So I'm here on the main campus in I don't know, Darlinghurst, not Darlinghurst, in Camperdown. And so it's the Gadigal people urination for me today, and I want to pay my respects to them. So thank you. Yeah, we've done the introductions. And I guess I might hand over to Julie, who's going to do the presentation now.
G'day guys, my name is Julie. I have a background, my mob come from Kimberley mob. So what we're presented today, I guess, is more of a protocol and a rationale for the OLAM project because it's still underway. We don't actually have any results yet. As part of this presentation, therefore, I'm also going to introduce two previous studies that the same group at NCRED have done. These are the Lima trial and the OLAM pilot study. The reason I wanted to talk about those is because both of them have informed the justification and the rationale for the OLAM trial. And yeah, I also wanted to finally, at the end, introduce the main piece of work that I actually work on, which is the First Nations nested study, which is part of the OLAM trial specific to First Nations participants. I'd be more than happy in a year or two to come back and present more concrete results for OLAM and the First Nations nested study specifically. So this project has a significant list of investigators. Not all of these people work across both projects. Michael and I specifically work on the First Nations nested study. I also wanted to call out Double Yarragan and Wunjining, who are two Aboriginal organisations at the very end there that have been integral in part of our ethics applications. I have some declarations just before I get started. Both Michael and I are employed by the University of Sydney, but OLAM and Lima are predominantly being conducted by the National Centre for Clinical Research into Emerging Drugs. Studies I report here are funded by the NHMRC with additional funding from St Vincent's Curran Foundation and Inclusive Health Fund, the Edith Collins Centre, Victoria Health and NCRED itself, which is funded by the Australian Government Department of Health, Disability and Ageing. Some of these slides have been adapted with permission from an existing presentation by Dr. Julie Matheson, and I have no further conflicts to declare. So some background before I dive into the actual studies that we're going to talk about. So 36 million people worldwide use amphetamine type substances, including methamphetamine. Methamphetamine use is associated with physical, psychological, and social harms, as well as increased mortality. And cessation of methamphetamine use leads to a really characteristic withdrawal syndrome, which drives that return to use again. So our current evidence provides really limited support for psychosocial interventions for methamphetamine dependence. Effectiveness is really weak amongst those who use very frequently, or at least half of the days in a month. We don't really have any evidence for treatments for methamphetamine withdrawal specifically, apart from symptom management. And in contrast to other disorders, there are no approved pharmacotherapies for this condition. So based specifically on Australian data, we're starting to see a continued increase in episodes where methamphetamine is the main drug of concern for people who are seeking access to treatment. Access to withdrawal treatment, access to withdrawal support is increasing after peaking in 2018. And note that Australia has the highest prevalence of methamphetamine dependence globally, at roughly 7 times the average. So the option that we're looking at to address this problem is agonist therapies. I'm sure everyone here knows what that means, but in case you don't, it means using a chemical that's different to, in this case, methamphetamine, which still activates the same receptors in the body to elicit the same or weaker biological response. The goal of this is to reduce the reinforcing effects that drive people to continue using methamphetamine. So specifically, things like negative reinforcement. So for instance, if you have withdrawal symptoms like anhedonia, anxiety, or sleep disruptions, you might return to using methamphetamine to escape those symptoms. Or we also would like to reduce the rewarding positive effects of taking the drug, for instance, like euphoria or those positive experiences associated with methamphetamine. We have evidence from other disorders like nicotine and opioids that agonist therapies can be quite helpful at helping people reduce their drug use. And the evidence that we have suggests that effective withdrawal treatment for methamphetamine could improve treatment outcomes for people who want to come off it by reducing that drive to return to use. So The specific drug that we're investigating in this instance for OLAM is Lisdexamfetamine, which is taken orally. It is a prodrug of dexamphetamine, and it's a stimulant medication that is currently licensed for use in ADHD and binge eating disorder at doses of up to 70 milligrams a day. However, previous research by our group and others has demonstrated that doses of up to and including 250 milligrams a day is safe for our population of people who use stimulants regularly. In the body, lisdexamfetamine is hydrolyzed into lysine and dexamphetamine in the red blood cells. The advantage of using lisdexamfetamine in this instance is that it doesn't contain any free dexamphetamine. The red blood cells need to convert it into dexamphetamine over time, meaning that it's slow onset, it has lower peak concentration than equivalent doses of dexamphetamine, and it has a much longer duration of action. So the potential for recreational use is comparatively really low, but the long-acting nature means that it's just a once-a-day intervention for clients, which really reduces that burden of treatment. Our research group, as I said before, has previously done a pilot study, which I'll talk about shortly, using lisdexamfetamine to address methamphetamine withdrawal. And we found that it was safe and tolerable for participants at doses of up to 250 milligrams a day. So, out of the 4 studies that I want to present today, the main one being OLAM, obviously, I'd like to briefly introduce you to a previous study that gives a little bit of context for why the OLAM project is targeting withdrawal specifically. This is the lisdexamfetamine in the treatment of methamphetamine dependence RCT, aka the LIMA trial. So this study was designed to test the efficacy of a daily dose of 250 milligrams lisdexamfetamine for reducing methamphetamine use in people who are dependent. It was designed as a randomized, double-blind, placebo-controlled trial, and it was delivered in 6 specialist outpatient clinics in Adelaide, Melbourne, Newcastle, and Sydney, Australia between 2018 and 2021. Participants were included in the study if they met the ICD-10 criteria for methamphetamine dependence and if they had used methamphetamine for 14 out of the previous 28 days. This is the broad overview of the intervention. It's quite simple. It was designed to be 15 weeks in duration. In the first week, there was an induction phase of 150 milligrams of lisdexamfetamine, which increased to 250 milligrams daily between weeks 2 and 13. And then it tapered to 150 milligrams in week 14 and 50 milligrams in week 15. All participants in this trial were also offered 4 sessions of CBT as part of their treatment. So the participants in this trial were broadly reflective of the demographic that accessed methamphetamine treatment. They averaged in age 39 years old, and they were predominantly male with high rates of methamphetamine use. Participants averaged around 24 days of use out of the previous 28 days. The outcome that this study was most interested in was the between-group difference in the number of days of self-reported methamphetamine use in the past 28 days at the end of the 12-week maintenance period, which I know is a mouthful. This graph really shows how many days out of the previous 28 that the participants in each group reported using methamphetamine. There was weak evidence of lisdexamfetamine being associated with reduced days of use by week 13 of the study, and the difference was diminished by week 19. However, there were significant reductions in days of use in the earlier parts of the study. So in short, this suggested that lisdexamfetamine reduced use of methamphetamine early in treatment when compared to the placebo group, but that the effect wasn't maintained over the course of the entire study. So this suggests that lisdexamfetamine might be more useful specifically in the early stages of reducing use. Other outcomes of interest for this study were safety and treatment satisfaction. For safety, there was no difference in serious adverse events between groups. Nausea was more common in the lisdexamfetamine group, but there was no between group differences in mean heart rate or systolic blood pressure, but diastolic blood pressure was higher in the lisdexamfetamine group at weeks 5 and 8. As far as treatment satisfaction went, people in the lisdexamfetamine group rated their experience higher than the placebo group on measures of treatment effectiveness and treatment satisfaction. And CBT didn't show any between group differences. Sorry, this slide. CBT didn't show any between group differences with a mean of 1 session attendance per participant. So with the understanding that lisdexamfetamine might be most useful in the early stages of reducing methamphetamine use, I want to move on to the next study that is in the series, which is the OLAM pilot. This study was designed to determine specifically the feasibility and safety of a tapering dose of lisdexamfetamine for methamphetamine withdrawal. It was designed as an open-label, single-arm pilot clinical trial operating out of the Inpatient Withdrawal Management Unit at St Vincent's Hospital, Sydney in 2021. Participants were included if they were adults that met the, I believe, DSM-5 criteria for methamphetamine dependence, if they were seeking inpatient methamphetamine withdrawal management, and if they had recently used methamphetamine. For this intervention, clients were brought in for a 7-day inpatient stay at St Vincent's Hospital. The lisdexamfetamine that they were given was formulated in 50 milligram capsules and dispensed each morning under supervision. So going through the blue boxes here, on day 0 after recruitment, they were screened to ensure that they were still eligible for the study. On days 1 to 5, they received a tapering dose of lisdexamfetamine, beginning at 250 milligrams and reducing by 50 milligrams a day, as you can see in the bottom boxes. All participants also received treatment as usual during this day. That includes things like symptom management and supportive care, so benzodiazepines for anxiety, for instance. Participants then also had a 2-day washout period on days 6 to 7 where they didn't actually receive any study drug. And then they were followed up after discharge on days 14, 21, and 28. Since it was only a pilot, and as I'll go into it again shortly, it was constrained a little bit by COVID-19. Only 10 participants were recruited in this study. They were largely representative of the target population with a mean age of 37. However, there was a really significantly higher percentage of male participants, with 9 male and 1 female. Participants in the study had been using methamphetamine for an average of 13.6 years prior to admission, and they had used methamphetamine on 23 out of the 28 previous days upon admission. On average, they would use 0.6 grams of methamphetamine per day, and they were mixed on whether they used it by smoking or injecting the drug. About 50% of the participants reported recent use of either GHB or cannabis, respectively, and no recent opioid use was reported. Again, for safety, out of 47 adverse events that were reported, only 17 were causally related. Most of these were related to things like GI issues or headache or trouble sleeping, and they were all considered mild in severity. There was only one serious adverse event that was recorded, but that was a case of shigellosis that was considered unrelated to the intervention, and no AEs were related to vital statistics. For feasibility, recruitment was negatively impacted by COVID-19, as I mentioned before. There was a restriction on the recruitment period to 126 days. 1/4 of the potential participants were recruited for the study as a result. However, with that said, the study was still considered feasible due to the high rate of recruitment within that period. Despite being only a single site and having no advertising, no active recruitment, the study still recruited a new participant every 12.6 days. Participants who were in the study reported that the intervention was highly acceptable and helped make withdrawal easier. However, obviously we didn't have a placebo control for the pilot. Both withdrawal severity and craving for methamphetamine reduced for the participants in the pilot over the course of their participation. In the course of withdrawal, specifically on the left, the reductions remained stable up to day 28, and participants had like a linear reduction in withdrawal severity over the first 5 days. They experienced a small rebound of withdrawal severity on day 6, which suggests that since that was the first day that they didn't have lisdexamfetamine, that was a small rebound. Finally, I'd like to present the main study that we're currently working on, which is the lisdexamfetamine for methamphetamine withdrawal clinical trial, or OLAM for short. As I mentioned before, this trial is still ongoing, so I'll just talk through the protocol and study design. So the aim of OLAM is to determine the efficacy of a tapering dose regimen of lisdexamfetamine at reducing the symptoms of acute methamphetamine withdrawal over a 7-day inpatient period. It's designed as a randomized, double-blind, placebo-controlled trial, and it's being delivered across 5 inpatient withdrawal management units in Perth, Melbourne, Newcastle, and Sydney, Australia, from 2025 to a planned end date of 2027. Participants are accepted into the study if they are adults with methamphetamine use disorder, as characterized by the DSM-5, if they are seeking inpatient methamphetamine withdrawal management, and if they had recently used methamphetamine. The structure of this intervention for OLAM is largely the same as the pilot. As you can see, it's pretty much the same thing. I have underlined and bolded the differences, however. The main differences are that OLAM participants are now randomized on day 0 immediately after screening into either the lisdexamfetamine or the placebo group. Participants are blinded both to the fact that they, to which group they are assigned to, but also to the tapering schedule. So essentially, they don't know exactly when the lisdexamfetamine tapering ends. We also kept participants in inpatient care for days 6 and 7 to address any of that rebound withdrawal that we saw in the pilot, and we extended follow-up up to 84 days. So currently, the OLAM trial is underway in 3 locations across New South Wales. The first is St Vincent's Hospital, Sydney. We also have Concord Repatriation General Hospital, also in Sydney, and Belmont Hospital in Newcastle. We also have it active in our Melbourne site, Box Hill Hospital, and we plan to expand the study to an additional site in Perth, WA. So far, we have screened 41 participants across all sites, with 38 of those being enrolled, 36 starting their medication, 19 having completed the full course of inpatient treatment up to day 7, and 13 having completed the final follow-up at day 83. So these numbers were correct as of yesterday. Obviously, they'll change with time. And finally, the OLAM trial has 2 sub-studies. One of them I won't touch on because I don't know as much about it, but the other is my actual concentrated area of work, which is the First Nations nested study. So the background of the nested study is that First Nations people have very specific challenges when it comes to methamphetamine. There's dispossession, generational trauma, ongoing socioeconomic disadvantage, all of which contribute to being much more likely to use methamphetamine than non-First Nations people. There are limited treatment options available, especially on country or in rural areas, and First Nations people who do seek out treatment may experience over the course of that treatment things like racism, discrimination, or stigma. There is lots of data on demographics and rates of use amongst Aboriginal and Torres Strait Islander people, but there's very limited data on what treatments are actually effective for this specific population. So with that in mind, the First Nations sub-study has 2 major aims. The first is specific to OLAM. We want to find out whether OLAM was appropriate and effective for First Nations participants specifically. The second one is much broader. We want to address that gap in the literature to find out what the needs and experiences of First Nations people in treatment are, especially specifically for methamphetamine treatment. So this is a qualitative study. It includes 2 different interviews at 2 different parts of the participant's journey. They're conducted with myself. As I mentioned before, I come from Kimberley mob. The interviews use a yarning methodology, which is semi-structured, very relaxed, very conversational, and importantly, it's participant-directed. So my role is to be an active learner and occasionally dive deeper into topics of interest, but participants are free to talk about whatever they would like to talk about. Each interview begins with a social yarn, so just chatting, developing rapport and making sure people feel comfortable before I shift the conversation to the topics of interest that are in our semi-structured interview guide. This is a really well-established method that is considered culturally safe in First Nations research. And this study also has First Nations ownership at every stage, meaning that the project has been designed, developed, and led by First Nations people. Michael Doyle was integral in the design of the study, and we also have support from an Aboriginal reference group who advises ongoing, and We have corporations, as I mentioned before, like Durban, Yarragon, and Wunjing in Western Australia. As I mentioned before, the yarning nature of these interviews means that participants can direct the interview as they wish. However, we do have topics of interest that I like to draw back to. I do have a more complete interview guide, but I don't necessarily strictly stick to it during the interviews, depending on what the participant would like to talk about. The first interview is conducted on day 7, preferably if my schedule allows, I would like to actually conduct this interview in person rather than over the phone. It's done on the final day of the participant's inpatient period on day 7. And it's generally about topics that are related to the OLAM trial itself. For instance, their expectations about the trial before they went in, whether they found it helpful or how it could be improved, what their past treatment experiences were like, whether that's good or bad, any cultural needs or social supports they might have, and any plans that they have for after treatment. The second interview is much more general, and it's usually conducted over the phone. I do it 2 weeks after the first interview, so after the participant has been discharged. And it's about topics that are more general and more about like your experience during treatment overall. So did OLAM meet their expectations? What was missing? What was their experience post-treatment? What their past experiences have been like again, and what other supports are needed. So as I mentioned before, this is ongoing. We're currently rolling out the First Nations nested study in New South Wales locations specifically, and we expect to roll it out in Victoria and Western Australia at some point in the future. Out of the 36 participants enrolled in OLAM overall, 8 participants have been eligible for the nested study, 6 have consented to the study, and this is roughly 6 have completed the first interview and 3 have completed the second interview. Of the 3 that did not complete the second interview, I believe 2 were lost to follow-up and 1 it was deemed unsuitable due to unrelated adverse event. We actually expected that roughly 20% of participants in OLAM would be Aboriginal and Torres Strait Islander, so this is within our expectations. The outcomes that we're looking at are pretty much directly tied to our aims. The first outcome, as I said before, is obviously an understanding of whether OLAM is appropriate and effective for First Nations populations, especially what we can do to improve the experience for that population. The other outcome is for us to have a better understanding of the needs of First Nations people in treatment, including how those needs can be addressed. As I mentioned before, there's really limited data on what treatment methods work for this population, so we're really anticipating that the data we get from these interviews will help guide the development of better treatment options in the future. So, as I mentioned before, recruitment is ongoing in New South Wales and Victoria. There's a QR code on the screen just there. Please, if you have any clients that might be eligible, please feel free to use that to access the referral form. But otherwise, I'd love to take any questions.
Amazing. Thank you so much, Julie. It was really interesting to see the kind of exploration around finding an agonist treatment for methamphetamine withdrawal. It's definitely been something that's of interest to the area for quite some time, especially, with heroin and nicotine, as you said, already having these substitute therapies. Is it possible to find something that might work for methamphetamine? We've got a few minutes for questions, so if anyone has any, please put them in the Q&A box. I guess I've got a couple that I'd love to know a little bit more about. I know it's very early, and I really loved your yarning methodology that you spoke to around that social yarn and then going into that semi-structured and letting it be guided by the participants. Are there any sort of preliminary themes or things that you feel that you've heard a few times, particularly in that first yarn where it's been, I think you had 6 participants so far? I mean, obviously, these are subject to change and proper analysis, but I'd just love to know if there's anything that you feel like you keep hearing from people.
That's a really good question. I think 6 interviews is very small, but I think the recurring thing that I keep hearing is that there needs to be more treatment in rural areas that's accessible, and then the other being there needs to be Aboriginal members of staff, is the other one that I keep hearing a lot about. Some people who are Aboriginal and Torres Strait Islander might experience like double stigma, and it can be quite helpful. I've heard from a few of them that if they have a member of staff that they can talk to about that, it's very, very good. Otherwise, I would have to have another look at some of the data. I think those are the main two that are really coming through.
Yeah, I'm not surprised stigma is showing up. We know that there's sort of high levels associated with methamphetamine, and as you say, I can only imagine the sort of compounding effects of that. I was wondering about the protocol a bit for OLAM participants. Do they have to go to the service every day, or do they get kind of like a take-home pack with their medications for 2 weeks? So how does that kind of process work?
It's an inpatient intervention. So the
Okay.
participants are actually in hospital for 7 days, which can be quite intensive for a lot of participants, obviously. So yeah, I believe Lima gave a take-home pack, but yeah, OLAM is specifically hospital-based.
Interesting. And so, yeah, I can see why potentially having First Nations staff would be so important then as part of that.
Yeah.
And Michael, feel free to chip in with any insights that you feel like you've seen over the trial at any time. One thing I know that treatment centres often report when people seek help for methamphetamine use is that retention can be a barrier. Have you seen that much in this trial? Is that something that, you know, that they're looking at to see?
I think, and again, like the overarching OLAM project isn't really my area. However, I do know that we've been having some problems in some sites, specifically where participants are unable to smoke. And it seems to be quite a demand for some participants to be able to give up both methamphetamine and smoking at the same time. From the last update that I saw, I think some of our sites are having excellent, like 100% retention, and others are experiencing that fallout. And it seems to be, specifically smoking seems to be a common cause of that. Because again, like people are kept in a hospital for 7 days, and most hospitals won't allow smoking, and yeah, it's a complicated problem that we're currently working through. Yeah.
Yeah, for sure. I guess two people are really keen to know if the trial is going to be expanded into Queensland and Northern Territory.
I believe at the
Tell us
moment...
your grand plans for this trial.
I don't believe this trial is going to be expanded out to there. I would need to refer everyone back to Nadine Izzard or other members of NCRED to kind of delve more into that. But at this stage, it's just the 3 sites in New South Wales, 1 in Victoria and 1 in Perth. Yeah.
And, you know, potentially, Michael, could you touch on, do you know why those sites were specifically chosen? Was it really just based around where good collaborations were?
Yeah, a bit of the latter, good collaborations, but there's limited funding with research projects, and so it's had a focus in a particular area. It's hoped that if this works really well, then perhaps there would be a sort of application for this in sort of less clinical settings, like more like general practice and that kind of thing. But yeah, that's where we're at this point in time.
Yeah, I mean, funding is always a barrier for so many things. But hopefully with some great trial outcomes, you'll be able to look at further expanding it and seeing where it goes. Another question that's kind of come through is, what should clients expect in this trial? So if you're signing up, what are the sort of expectations? I think you touched a little bit on how it's really targeting withdrawal and craving. Would you say that that's accurate?
Yes, that is the specific main targets. We want to reduce the withdrawal effects and specifically craving and the withdrawal symptoms, which can be quite difficult for some people to work through. We also do provide at each location treatment as usual, just the gold standard of everything else. So things like any behavioral or psychosocial or other medications, I believe, are also on the table. So things like benzodiazepines for anxiety, which I touched on earlier, they might be diagnosed depending. It's basically a standard inpatient withdrawal management program, but with the addition of either a placebo or lisdexamfetamine. We're really hoping that it just really helps reduce those side effects. Specifically for the First Nations side, we're really hoping, again, like I mentioned, to find out what the difficulties are, specifically for First Nations people. So yeah, we'd love to hear from them as well.
Yeah, for sure. And that reminds me of a question that was sort of asked a little bit earlier, particularly around that pilot study, and you may or may not know, which is totally fine, is when were the CBT sessions offered? I think you said there were up to 6 available.
Up to
was
4.
It was 4?
Yeah, and I believe it was during... Actually, no, I probably shouldn't answer. I don't know well enough off the top of my head. I apologize.
No, it's a very... Yeah.
It was during the course of the treatment. So, but from what I recall from learning about it, because I didn't actually work on that pilot, it was very low retention. Very, very few people actually took it up.
And I guess if we've got a question here from someone who's overseas, and they were just wondering about the cultural differences and the possibility of Aboriginal people do not know or trust you. How would you consider veracity of the conversation? If I guess it's talking a little bit about how are you building that kind of sense of trust with people to really get, as you say, like to the questions that you have around what are the barriers for people?
That's a really interesting question, and I kind of customize it to each participant that I speak to. One of my main priorities at the very start of each interview is to build that rapport, and so I introduce myself as Kimberley, and I am very free with, like, if a participant asks me questions, I will answer everything and just kind of try and position myself as on their team and, interested in their experiences, but also, yeah, just sharing a little bit about myself as well. The veracity, I don't know if there's a way for me to like be 100% certain that each person is telling me the absolute truth, but I will say that majority of the people that I talk to are very, very keen to be heard. I have not really had any experiences where I've come away from an interview feeling that somebody was not really excited to have this be something that we were investigating, I guess. Because I do, introduce the study to them at the very start, and I say what the purpose of it is, and people are very excited to actually have this be something that we're working on. So I guess, does that answer the question?
Definitely, yeah. And I was just also thinking, perhaps Michael, like on your reflections in general, because you've been working in this AOD space for so long, how have you found engaging, particularly with First Nations people? Like, is alcohol and drugs something that they are keen to sort of talk about and share their experiences when they feel sort of safe and supported?
Yeah, look, thanks, Steph. Yeah, from a research perspective, what I've found that tends to happen as an Aboriginal researcher, once they get to know that you are an Aboriginal person as well, there's a whole bunch of stuff you don't have to explain. You don't have to explain the legacy of colonization. You don't have to explain how that may have impacted you personally or family. There's this understanding, and so you kind of move into a different sort of level of familiarity and trust within a very short period of time. And so you kind of tend to open up a bit more. And this came through in all kinds of research I've done. Back in the day, the PhD research, the guys in the prison said, yeah, you just automatically trust the other fellows when you're in a therapeutic group. And then they kind of said that's like extended to you, of course, because you're one of the brothers as well, even though I was there as a researcher. So you're not as guarded with some information as you might be. So yeah, it makes a big difference. And I think the interpretation of the research makes a big difference when you have an Aboriginal lens as well. When you consider the context of the data that you're getting back and some of the words and meanings maybe a little bit different. Like commonly we say deadly might mean really, really good. I'm sure people online have heard that sort of expressed before, but there are things that come up that are a little bit different. Yeah, I think we need to have more Aboriginal researchers in this space, and I think Julie's doing an amazing job.
Yeah.
Yeah, definitely. And it's just, yeah, as you touched on, it's so important to have Aboriginal-led research, but also Aboriginal ownership and governance over your whole project as well. It's great to see. And how do you find sort of working with that kind of expert advisory group?
So the reference group we're talking about is the Edith Collins Centre's Aboriginal reference group. And so we've got a number of projects that are put through the reference group. It works really well. A lot of people are the people you invite onto these reference groups tend to be people with some level of expertise or lived experience in that particular field. And so we're in drug and alcohol. And so people are have worked in the field or researched in the field. It's incredibly helpful. Sometimes I might have a fairly good idea about what something means, but I can't let that drive the analysis as well, if you get what I mean. And then talking through some of the results with the reference group, kind of then they may say similar things to what I was thinking, which kind of helps me think, yeah, that was we were kind of okay there. But yeah, it's what else can I say? Yeah, it's very good in building having that kind of advice and building connections between things that might not necessarily be immediately obvious to you as a researcher. So just an abstract thing about sort of, I don't know, people coming out of jail and then um, getting their first Centrelink payment, having housing insecurity, and how that sort of flows on. And we kind of know some of these things, but there's contextual detail that a reference group might fill in when we sort of say that there's a particular difficulty or a particular issue that several participants spoke about. Yeah, it can be very, very helpful.
Yeah, great. And yes, when you were talking, it's always so hard not to bias the results based on what you think is happening and to always like approach research with an open mind. I'm sure, Julie, it's something you're experiencing as a PhD student. Yeah.
I'm not a PhD student at this stage, but maybe in the future.
Oh, what is the word? I'm putting it out into the atmosphere to lure you on that path, perhaps. Sorry about that.
No, you're good.
Do you think that this treatment or any sort of agonist substitution therapy might be something that could be used in other settings, potentially around correctional facilities through Justice Health? I know we've seen it rolling out in New South Wales of opiate agonist treatment. Is this something you could see similarly in the future, whether it be 5-10 years down the track?
I think this is definitely a question for Michael.
So everybody online, you heard Julie say yes with the pen.
Yeah, we did it. We got her over.
Yeah, have a recording of that. No pressure, Julie. Look, I think we should remember it's one part of the puzzle. It is the sort of clinical agonist treatment, if you like. And so the other parts are that we do need community sort of support. We need behavioural treatment. Somebody mentioned about the CBT, that like CBT alone kind of doesn't do it all, neither does the medication sort of side of stuff, and we need these things to be happening together in a supportive way. One of the big challenges, of course, is housing insecurity. That comes up across every single research project in every domain and everything. And so there are these underlying factors that people are not sort of excluded from, if you like. If you're in a study, you still have the general sort of background of socioeconomic challenges that people might have. As well as over-policing and racism and discrimination, which Julie spoke about. So it sounds a bit depressing, what I'm saying, but this is very good that we go ahead and look at this aspect. But when moving further down the line, it's really, really important to think about it as part of the toolbox rather than the toolbox itself.
And that is part of the reason why we're not just looking at the experiences of people in the OLAM trial, but like their experiences outside of OLAM and like past experiences and things like that. It's not necessarily related specifically to prison populations, obviously, but we want to kind of build that toolbox as well and find what other things might be helpful even outside of the agonist treatment.
Yeah, for sure. You know, we all know that there's many reasons why people may be using drugs, and so just sort of swapping that out for something else isn't necessarily going to fix whatever underlying or other needs that that person might have. And I guess outside of smoking, was there any other limitations that you kind of saw across the trial to retention?
I know that for myself personally, we lost 2 participants to follow up, and that was purely due to, I believe, from what I understand, both of them no longer had a phone. So even simple things like that, because the nature of once we've discharged them, we need to be able to contact them either by a phone or email. And if they don't have a phone, if they've lost housing or something along those lines, then we're going to lose contact with them. During the study, I would need to check for any particular reasons, because I know that the smoking thing has been very much an ongoing thing that we've kind of concentrated on because it is something that is theoretically fixable. I would need to double check what the other potential causes for loss of retention would be. Yeah.
Yeah, no worries. Oh, Michael, did you have anything you wanted to add to that?
We could probably comment more fully on that in 12 months' time.
Exactly, that too.
Well, along with signing Julie up for a PhD, it sounds like I just guaranteed myself another webinar. This is going great, everyone. And I guess one of the questions kind of is how much longer is the trial sort of scheduled to go? And what might be the next steps after the trial, or is that kind of really dependent on what the findings of the trial are and where that might lead to next?
Well, you've answered part of my question. It's scheduled to go on until 2027. I would need to double check with the team whether there's any expectation that we extend the study a little bit, because I know that some of the sites, due to matters that were outside of our control, we did launch at a couple of sites a little bit later than expected. But yeah, as of right now, I believe it continues on until late 2027. So afterwards, what are our expectations for after the First Nations study, Michael?
We would be immediately thinking about what would be the possibility for rollout in more general practice type settings that might not be an inpatient setting. That's something we've discussed already, but there's a whole bunch. We'd need the clinicians involved in the trial to discuss that as well, of course. But yeah, I think there's a real desire for more treatment in this space in the community. Aboriginal community is generally a lot of people are very concerned about methamphetamine use and are looking for whatever it is that could perhaps help, even just a little bit. We thought could make a sort of significant difference, I guess. So yeah, we'll see how we go, and happy to come back in 12 months. What I was saying, perhaps have a bit more of a conversation about those things.
Yeah, great. Well, I'll ask one more question and then I'll let you go. You've done an amazing presentation, Julie, and I've really had you in the hot seat with all these questions. I appreciate both of your time, Michael and Julie. Just wondering, because psychosis does happen quite often with methamphetamine use, particularly when it's heavy and consistent, if a participant had psychosis as part of their withdrawal, someone was wondering, were they taken off the trial? Were they screened out before they got to the trial?
I believe, if I remember correctly, but I would need to double check. If I remember correctly, they were screened out early on and it would probably be considered an adverse event, but I would need to double check. I believe it was one of the exclusion criteria, unless there was compelling evidence that, you know, it was not related to the methamphetamine, but yeah.
Yeah, from my experiences with clinical trials, not that I've ever had the been involved in running one, I know that the inclusion exclusion criteria is very tight to try and really get at is that medication making a difference or not.
Yeah.
So I can imagine, yeah, the inclusion exclusion criteria for this one. Well, thank you both so much for your time today. Really appreciated you sharing the studies and where you're up to, and looking forward to hearing next steps, particularly how the yarns progress and what you find out through them. Thank you to everyone who joined us today. You're more than welcome to get in touch if you have any questions, and we'll be holding further webinars throughout the year. So please feel free to sign up to the Cracks in the Ice mailing list if you haven't already. And so thank you again, Julie and Michael, and we hope everyone has a wonderful rest of the day.
Thank you so much.
Thank you. Bye.